are on. All right, well, welcome everyone. Very pleased to have you here at the Center for Advocacy and Social Justice. My name is Dennis Stone, Director of the Center, and really grateful for all the support we have gotten from the Jacksonville Urban League, the Jacksonville Urban League Young Professionals, and the Jacksonville Urban League Guild for this evening town hall on access to oral health care. I was, I would say, amazed at what I've learned. I am amazed at what I've learned in the last several months working with Dr. Frank Catalanotto and others in this field about how impactful the lack of dental care is on children and families throughout the country, but particularly in our area. And we're going to learn a lot more about that. And we're also grateful for the support we've gotten from Community Catalyst and Floridians for Dental Access in enabling us to research and get much more deeply into this area. Several of our interns are with us, and Kyle Basinger and Teresa Sanders are going to guide us through our speakers, and they have gotten deeply into this as well. And it's part of the program of the Center for Advocacy and Social Justice to engage some of our best students from higher ed organizations to research in areas of importance to our community. And we're grateful to have them with us as well. And at this point, I will turn it over to Kyle Basinger to go through the agenda, and then we will have Dr. Danford, president of the Urban League, to start us off. Kyle?
Thank you, sir. We will be starting off this evening with a video presentation made by Ms. Tamika Smith that just speaks a little bit to the issue that we're dealing with and trying to tackle this evening. So we will be beginning with that. After that, we will have our panel of experts, starting with Dr. Elstein, followed up by Dr. Catalanotto, and ending with Ms. Amy Liam. They will each be speaking on different aspects of this problem, from a national perspective to a Florida perspective to laws implicating access to dental health. So Dr. Danford, if you'd like to give your introductory remarks, and then we will begin the video.
Sure. First of all, let me say good evening to all of you. I'm Richard Danford, president of Jacksonville Urban League. I've been around quite a while. I want you to know how pleased we are to have this relationship, or this partnership really, with Floridians for Dental Access. This is a very important issue for urban leagues. We've been around here in Jacksonville for over 70 years, and we're part of a movement where we have at least, I believe, about 90 urban league affiliates around the country. We have 7 affiliates here in the state of Florida, and I'm pleased to say that all of our urban leagues have taken on this challenge. All of us are working extremely hard to empower communities and change lives. The health arena is very important to us. We serve many of our clients, the majority of whom are African Americans and other minorities, and health across the board is extremely important. And we don't normally think about dental health, dental access. We just don't do that. And we have an opportunity to push forward some opportunities to increase dental access, certainly for minorities in this community. And we'll hear more about that from our speakers. But the point I want to make is that this is an important area that we're involved in, and we're happy to be with you. We will answer questions and we'll participate. And I want to personally thank our interns who are joining us and for your support. And we're hopeful that you will have a meaningful educational experience while working with us here at the Urban League. I also want to thank Frank for his encouragement and his persistence in doing the right thing. And I've learned a lot from him in such a short time. And I want him to know that we have his back. He may not think so sometimes, but we're with him in this endeavor. And I believe at the end, you will see some important positive outcomes. So with that, welcome to all of you and those who are joining us in our work here at the Urban League.
Thank you, sir. If anyone has any questions during the video or during any of our speakers, if you could please put them in the chat box, and we will try and cover them at the appropriate time.
Oral health is essential to general health and well-being. Oral disease can cause pain and infections that may lead to problems with eating, speaking, and learning. In 2017, only 39 to 40% of Medicaid-eligible children in Florida received any dental services. That year, more than 2.7 million children were actually eligible for Medicaid in Florida. This means that more than 1.7 million children who had Medicaid did not receive any dental services. Children with poor oral health are more likely to experience oral pain, miss school, and are more than twice as likely to perform poorly in school. And while we may know the importance of oral health care, the number of adults in America who use oral health services is going down. Some of the reasons for this decline are cost, geographic location, and availability of dental providers. These barriers exist nationally, and they also exist right here in the great state of Florida.
For me, there's about 20, 30 minutes. It's not like I can go up the street to the dentist. It's just the area just didn't have the providers, and it gets worse the further you go because they have one or two, and everybody knows the dentist.
Lack of communication from Medicaid can be a barrier to accessing oral health care for children. Outdated provider lists make it difficult for parents to find a dentist that will accept their insurance. In addition, parents may show up for a dental appointment only to be told that their children can't see their dentist because Medicaid changed their dental provider without the family's knowledge.
Yeah, I've learned my lesson. So to save time, I literally sometimes I do it the day before if I have time. So, when the doctor usually calls you to confirm, the doctor's office says, oh, are you guys still coming for tomorrow? Then it'll trigger me in my head to just call them and double check that that's still, our primary dentist. And then if I don't get that chance, my last resort is on the way to the dentist in the car, I will make the call. And just by the time we get there, it's confirmed that, they are, or either they switched it just now so it can be back under that person.
A growing body of research has identified a connection between oral health and chronic health diseases such as Alzheimer's disease, diabetes, and other serious conditions affecting millions of people. Gum disease in particular is associated with diabetes, heart disease, and stroke. In pregnant women, gum disease is also associated with premature birth and low birth weight. So while the Medicaid program has its challenges, parents are willing to jump through hoops, leaving no stone unturned to make sure that their children have routine dental care. These parents know that good oral health decisions now will have lifelong consequences for their children.
Medicaid is affordable. They're not without health insurance, and more specialists are accepting it, and they're provided care. It's a blessing to have it because it's extremely tough to have it because insurance is very expensive.
To share your story with us, visit healthcareforfl.org/stories.
Thank you, Jocelyn, and thank you to Ms. Smith for putting that video together. Next, we will have a CDC brief from Teresa.
Good evening, everyone. Again, my name is Teresa Rizzo-Sanders. I am an intern at the Center for Advocacy and Social Justice, and I'm just going to give you guys a brief overview of a report that the CDC came out with for the role of law and policy in increasing the use of oral health care system and services. So the report really goes over three main topics, which include financing, the dental workforce, as well as utilization. So as far as the financing piece goes, the policies that expanded dental insurance coverage through Medicaid, the Children's Health Insurance Program, or CHIP, and the Affordable Care Act led to the expanded use of dental services by children. None of these programs, however, mandate dental coverage for adults. And then for the workforce portion, the report focuses on the fact that dental providers are robust in numbers, but not in geographic distribution or in racial or ethnic diversity or socioeconomic background or diversity. This lack of availability and diversity likely contribute to the ongoing disparities in dental care. Non-traditional providers, including expanded function, dental assistants, and hygienists and dental therapists, hold promise to expand access for underserved populations. And then the utilization portion of the report speaks to the fact that even after overcoming the hurdles of financing and the issues with the workforce, there still remains issues of additional barriers that underserved populations face, such as transportation, immigration status, cultural competency, hours of service, and discrimination. These additional barriers serve to impede utilization in underserved communities, which impacts the use of preventative dental care and ultimately impacts overall oral health. So that's just a really brief overview of a very long and really important report. So that's all I have for that piece. Now we will move forward and start with the panel. So back to you, Kyle.
Thank you, Jocelyn, if you could bring up those slides. And thank you again to our panelists. And just begin whenever you all are ready.
Okay, Kyle, you'd like me to get started?
Yes, sir. I'm sorry.
Okay, well, I've been asked to address oral health and dental care from a national perspective. And while I truly appreciate that there are a myriad of ways that that topic could be covered, I've decided to focus on a single context. And that context has to do with something that Dr. Danford mentioned in his opening remarks, which was a distinction between oral health and dental care. So I think for us as advocates, for us as people seeking to correct social injustices, it is important to keep in mind a context. So if I could have that slide. I wanted to state that, in fact, the problems we're addressing here, significant social gradients in both oral health and dental care, constitute a social justice problem. It has been said that oral health and dental care are the best examples of the worst case of disparity in the health sphere. And that has to do with the fact that, as Dr. Danford mentioned, it's often not thought of. It's often seen as secondary. People who experience the greatest oral disease burden have the least access to dental care. Now, when you take a look at those two things together, would suggest, go ahead, Jocelyn, logic would suggest that if you improve dental care access, then you would automatically improve individual and population oral health. Securing equity in dental care is going to take care of oral health disparities. That's very logical, but is it true? Is it so? Well, next one. It might be that something else, something different, is needed to improve population oral health. So let's take a look at where we get oral health in the next slide, and where we get oral health and what we can do to ensure that our focus on dental access is part of the solution and not the entire solution. This quote sums up very well the roles of other determinants of health. Here we go. Health has less to do with doctor's visits, medicine, and health insurance than we might think. It has a lot more to do with addressing barriers that impact health, such as poverty, environment, access to healthy foods, and built environment that make walking and exercise difficult. So, in fact, we get our health from a number of factors, and this pie chart shows that the proportions of these factors are very different than we might assume. So on the next one, we see that dental care, go ahead, click on that, constitutes only about 10% of our oral health status. And what we're really after is oral health equity. And we want to consider the role of dental care equity as a contributor, but it's not going to be a huge contributor. It's only about 10%. Clicking again, we see that health behaviors constitute nearly a third, and that is what we eat, whether we use fluorides, how we brush our teeth, social and economic factors like income insecurity and housing insecurity and food insecurity and immigration insecurity. Those are factors that contribute even a greater percentage. And the physical environment, including, for example, fluorides, make a difference, whether towns are fluoridated. And one thing that we can't change, or at least medical science not yet allows us to change, are our genes and biology. So if our goal is oral health, we should keep this pie chart in mind and focus very significantly on addressing social economic factors, health behavior factors, as well as clinical care on our way to improving oral health. Next slide. So once we distinguish access to care, we should consider what the content of care is that is capable of addressing these other issues. Access to care requires, as Teresa mentioned, somebody to provide that care, a workforce, somebody to pay for that care, and somebody to provide the delivery sites. And then utilization, once the doors are open, whether people walk through them, attends to a whole nother set of issues about physical and geographic barriers and culture and language barriers. Once we get people into dental care, we need to rethink what we mean by access to care by reconsidering the content of care. If we think of care only as dental procedures, then we miss the chance to allocate resources proportionate to need. So dental care, like healthcare, is now evolving to be more risk-based, that is proportionate to need, and more value or outcome oriented, thinking about the degree to which oral health care yields oral health. And dental care needs to evolve to be more focused on risk, more focused on the medical and pharmacological management of diseases to reduce those risks, and to meaningfully take part in these social justice issues of social and behavioral determinants. On the next slide, we have a picture of the cover of this document that Teresa mentioned, the role of law and policy in increasing the use of oral health care systems and services. As one of the authors of this report, I can share with you that we worked hard to maintain this distinction between just dental care in its traditional sense and the role of dental care in evolving in ways that truly address the full range of oral health determinants. So since it ended up being 99 pages is because we go well beyond considering payment, location of services, and workforce, as well as utilization, to consider the factors that are in the environment that impact social and behavioral determinants of health. I hope that was helpful.
Thank you very much, sir. So I think you covered it quite well, especially your chart. Would it be fair to say that the difference in oral health and dental access is that dental access is just one avenue or aspect of oral health?
One component. And certainly when people have acute pain and infection or dysfunction or poor dental appearance, then it's necessary to engage in dental repair. Before we get to dental repair, we should think about all the upstream issues. We should think about primary prevention. We should think about disease suppression. We should think about helping people gain access to healthful foods. Decay in children is a dietary disease. It's more of a dietary disease than a hygienic disease. Address food deserts for our patients. We are absolutely helping them achieve oral health. When we engage with soda taxes, we are absolutely helping with oral health. Environmental changes. When we ensure that the fluoridation is available, we're addressing oral health. And those are all things that the dental profession should join with the social justice and advocate workers in order to ensure. Going upstream is the name of the game.
Sure. And of those common barriers, what do you think we as organizations may be able to do to help with those?
I think in a phrase, my primary recommendation is to work on dental access, but don't think that that is the answer to the problem of equitable oral health. Keep in mind that we all need to work on the larger social, environmental, behavioral issues that carry more weight. So we don't want anybody to suffer. We don't want to take away dental care. We don't want to diminish the role of dental offices in educating families. The gap between educating a family and having it absolutely change their oral health behaviors. Let me give you a quick example. Know the role of sugar in tooth decay. But a mother who is struggling to put food on the table and has to stretch every single dollar or every single food stamp also knows that getting something on the table is more important than getting nothing on the table. And so we need to go upstream and think about the environment in which our patients go home and them have the resources that can make it. Another quick example. It showed that if you simply mail toothbrushes and toothpaste to high-risk families on a basis, that will help reduce tooth decay experience by providing them with the capacity to do what they know they need to do in the first place.
Well, thank you very much, sir, again, for your time and your perspective on that.
Thank you.
Our next speaker, thank you. Our next speaker will be Dr. Catalanoto, and he will be giving a Florida perspective on oral health.
So thank you very much, Kyle. It's a pleasure to be on this panel with Burton. He and I actually go back to the 70s in Connecticut when I was on the faculty at the dental school, and he was in practice in Connecticut. There's so much that he said that I'd like to use as an introduction to what I want to talk about, the Florida perspective. First, this whole issue of social determinants of health. He is right on target. Just fixing access to dental care is not going to solve this problem. His last example of a toothbrush, I want to share with you. A number of years ago, I was doing a piece with Frontline on NPR about access to dental care, and I related to the producer, a woman living in Washington, D.C., from a very upper middle class family, that we were dealing with patients, with families that shared a toothbrush. And she could not believe that. And I went around the corner to the office of a colleague who was the one who shared that story with me. And I had her speak to the producer, and it helped change the emphasis of that Frontline piece that eventually got produced. So let's go to the next slide. So what is the state of oral health in Florida? And I'm embarrassed to say that it is one of the most problematic states in the United States. And I want to just give you a couple of data tidbits that will illustrate this for you. So Florida Medicaid has very bad reimbursement rates. I don't blame dentists for not participating, but the result is that only less than 30% of Florida dentists actually participate in the Medicaid program, making it very difficult for those patients we heard in the video to access dental services. And the result of that is that only 40%, to update the numbers that were in that video, 41% of Medicaid eligible children in the prior year actually had any kind of a dental service. And you compare that to about 50% is the average nationally across the country. And of those who received any service, only about 37% received a preventive dental visit, the kind of thing that Dr. Edelstein emphasized, that prevention is so key in this whole issue. And another point that was mentioned by Dr. Edelstein. So Florida is, so the federal government defines dental health professional shortage areas as locations, it could be a zip code, it could be a county, that don't have the appropriate dentist population ratio. Florida has the largest number of people living in these dental health professional shortage areas than any other state in the country. And one more factor that's not on this slide. So when we look at oral health in children, third grade children are sort of the standard across states so that states can compare their success or lack of success in getting care to children. And there are about 30 states who report this data to federal agencies. Florida ranks 6th in terms of 25% of children, third graders examined, had untreated cavities, ranking 6th highest in the United States. So what is the result of lack of access to care? And we heard a little bit of that during the video. Children who have dental pain can't learn. And there's evidence to support that. There's a number of publications that support that. And the way out of poverty, the way to a better job is education. So that's why I think this is such an important issue. And the last comment I'd make before I get to talking about solutions is that there is also a great deal of evidence that people of color and Native American groups in this country, the richest country in the world, suffer even more disproportionately than the general population in terms of lack of access and poor oral health. So, what are one of the ways to improve at least access to care? And dental therapists are one of those solutions. There are others, and Dr. Edelstein again mentioned we can't just focus on access, but for the purposes of this discussion, we're going to focus on workforce. So dental therapists are members of the dental team who are trained and educated to the same level as dentists, but for a much more limited scope of procedures, what I sort of call the basic dental procedures, prevention procedures, counseling procedures, improving the parents' oral health literacy, and the restorative procedures. It's a 100-year-old profession. It started in New Zealand over 100 years ago. It's in place in over 50 countries, and it was started in the United States. Next slide. In Alaska. I think. Okay, I thought we had one more, but that's okay. 13 states that in some form or other have legislation passed to bring dental therapists to the dental workforce team, working under the supervision of a dentist. They hear some criticisms of this practitioner, this dental therapist, but I can assure you that 100% of the published literature about the quality and safety and cost effective of dental therapists supports their implementation. Our coalition, Floridians for Dental Access, has been working for, this is now our 4th year of trying to pass this legislation in the state of Florida. We welcome the new partnership this past year, the Urban League, and we hope the other Urban League affiliates will soon join our efforts. Pinellas already has, and we're working with the others. At this point, I think I'll stop, and we can answer questions that they come up during the question and answer period. Thanks, Kyle.
Thank you. Can everybody hear me?
Yeah.
Can everybody? There you go. Small technical difficulties. Can everybody hear me now?
Yeah, you're good now.
Yeah,
okay,
good.
Perfect. Thank you. So, Dr. Catalanoto, can you reiterate what the difference between dental access generally and dental therapy is?
So I think I want to put this in the context of what Dr. Edelstein said. So the care system, getting care to patients, giving them preventive services, filling cavities, preventing future infections, and things like that, that's the access issue. And what dental therapists have been proven to do in Alaska, Minnesota, Washington, and Oregon, where they're already in practice, is that they can help improve that access issue. The second thing is that we hope that dental therapy educational programs, as they are in Alaska, we hope in our state, are going to be based in state colleges, where it is more likely that the applicants and enrollees in those programs are going to reflect the diversity of our state. Because quite frankly, the dental workforce today does not reflect the diversity of our population. So that's the main difference that I would point out.
So just as dental therapy is one aspect of dental access, so dental access is one aspect of oral health.
Yes.
So what would you say are some of the local barriers we see in Florida to oral health?
So I think a very important barrier to recognize is cost. The American Dental Association Health Policy Institute points out that the biggest impediment for any individual to access dental care, and this cuts across income groups, is costs. The second issue is poor oral health literacy. If you don't know you need dental care, if you don't know how important it is for your child to be able to succeed in school, if you don't know that good oral health is very important in the management of your diabetes, the battle is lost. So we also try to focus on oral health literacy. The third issue, and this is really illustrated in that video, is geography, geographic distribution of dentists. The University of Florida College of Dentistry is one of the providers of Medicaid services for dental care, and we have patients that travel an hour and a half because they can't find a dentist locally in their area. And I also just have to add, because I should have added this at the beginning, when I'm talking tonight, I am only representing Floridians for Dental Access. I'm not representing any other organization with which I am affiliated. Sorry, I should have said that earlier.
Thank you. I think we had it in your introductory slide. So finally, what do you think we as organizations can do to help overcome some of those barriers?
So in terms of the workforce issue, I think that the members of the Oral Health Florida Coalition, and as of a couple of days ago, we're now at 61 organizational members across the state of Florida. And I should point out bipartisan, representing the political right and the political left, need to speak to legislators. They need to tell legislators that in 2017, Florida hospitals billed out $500 million. You heard me correctly, $500 million for emergency dental care and or hospitalizations because the infection was life-threatening. That should get you as citizens, us as citizens, and that should get legislators angry. And we should try to pass dental therapy legislation. The second thing we need to do is raise oral health literacy. We all have an obligation in our various roles to make sure that our constituents understand that oral health is important and people need to seek high quality, cost-effective dental care for their children and for themselves.
Well, thank you very much, sir.
Thank you.
And then our final speaker, I'm sorry, not our final speaker. Our next speaker is, oh, there's our list of states that currently have dental therapy. Our final speaker is Ms. Lee.
Thank you again, Ms. Lamb, for joining us. Today, we're going to switch kind of over from the perspective of the doctors over to a more focused position on the policy and the laws regarding the benefits that are available for patients that do have Medicaid, as Ms. Liam often works helping those individuals to navigate the system. So thank you again, Ms. Liam, for joining us. Could you go to the next slide, Jocelyn? Thank you. So we're just going to start with a few questions. So this first question is kind of a two-pronged question. Ms. Liam, can you please explain some of the laws and legal protections in place for individuals who would like to access dental care? And what laws do you think you have the greatest impact on accessibility?
Sure, absolutely. And it's such a pleasure to be here. And just to dive right in to answer the question, I'd have to say that Medicaid law and regulations, I think, really are key in this. And just to throw out some data, the latest enrollment data for Medicaid is 4.3 million Floridians right now as of this month. And that's an increase of over 500,000 just since last March. And of that 4.3 million, over half of those enrolled are children. So about 2.2 million children are receiving their health care, including their dental and oral care through Medicaid. And the video at the beginning was just excellent, and it did such a great job of kind of discussing and really highlighting or lowlighting some of the barriers and the problems that are occurring right now with Medicaid. And Dr. Catalanato pointed out some real concerns and issues we have as well. However, the Medicaid, though, does provide the benefits and rights and protections that if they really were implemented correctly, and if the laws and regulations were properly complied with, and if people, recipients, organizations and advocates like us were really made aware of the consumer rights and protections that existed and able to kind of share that and get the word out. And just people were provided the information of how to sort the rights under Medicaid, that it really could just have a huge impact. And just as an example, 2.1 million children would be getting the dental services that they need. And as one of the speakers pointed out earlier, it's around 30 or 40% right now. And that is even a huge improvement over what it was just a few years ago. So yes, we have historically had problems with Medicaid access, but the reality is if it were implemented correctly and if we can really get the care provided to the recipients who are entitled to it, then it really would be key at providing impact and providing access. And there are two particular areas with Medicaid and Medicaid regulations that I wanted to touch on real quickly because I think they're critical to dental access and oral health access issues. And one of them is specific to children's Medicaid benefits. But again, with 2.2 million children receiving their healthcare and dental care from Medicaid, that it's really very significant. And Medicaid benefits for children are really quite different from the adult Medicaid benefits. It's a much broader range of services and coverage, and there are more protections. So rather than adult Medicaid coverage, which historically is more about treating conditions rather than preventing them, children's Medicaid benefits, really the program or the benefits covered are supposed to emphasize prevention and screening, and they're designed to help children grow into healthy adults. It's, the federal laws refer to the children's benefits as the early and periodic screening and diagnosis and treatment program. That's one of the problems. Things can get really complicated with Medicaid, and we get titles like this that people aren't aware of, and we have federal levels with state levels, and here at the state level, we refer to it as something else, child health checkup program. And so that's just only kind of causes more confusion or just maybe a little bit more of uncertainty about what exactly is provided and how people can access services. But what's so important to remember, regardless of what we call it, what everybody needs to know is under Medicaid, children should be receiving whatever Medicaid services they need to, and the term is called correct or ameliorate a condition, and that could include diagnostic, screening, or preventive services. So just to kind of simply put, children should be receiving the healthcare they need. And of course, that includes very broad standard and comprehensive dental health care. And when they aren't able to access that, they're being wrongfully denied a Medicaid covered benefit. And so all these issues that we've talked about and the problems that we have with people not being able to access their Medicaid services, that form of a denial. And there are complaints and grievances and appeal processes all in place. But the reality is that not everybody is aware of them, and there are barriers in the system. So it's really key to understanding that children should be receiving these, and there are ways, legal rights around it. And the second area that I think is so important, it's something else that not widely known unless you are part of Medicaid agencies or really involved in it, providers or health plans, but it deals with how Florida Medicaid has chosen to implement its Medicaid state program. And in Florida, the Medicaid program is called the Statewide Medicaid Managed Care Program. And under that program, nearly all Medicaid recipients are required to enroll in and receive healthcare services, as well as their dental services, through a Medicaid managed care health plan and a Medicaid managed care dental health plan. And the state contracts with these plans to provide services. So almost nearly everyone is required to enroll in a Medicaid health plan. And when the state contracts with those plans, those contracts do have significant requirements that the plans must comply with. And they are designed to provide protections to Medicaid recipients, such as access to care, particularly timely access to care. The problem is, and what's really tricky about them is these protections aren't clearly set out in law and regulations, but they're in contracts. And who reads health plan contracts with the state agencies? I mean, it shouldn't be, Medicaid recipients shouldn't be required to do that. Advocates, providers, we shouldn't have to be looking for these consumer protections and digging through contracts that aren't readily available. However, they're there, and these protections are there. And so if we could really ensure that they are complied and make people aware of them, give them the ability and to appeal rights and kind of assert these protections that are there, I think it really would be key to helping increase access. And just to give you an idea of some of these protections that are provided in contract, plans must maintain a sufficient network of providers in order to be able to provide Medicaid services to all of the enrollees in that plan. And I think we talked about that there's not a sufficient number of providers, and but they're required by contract with the state to do this. And so to kind of force compliance and to make reports, to let the state know, to let our legislators know, to, when people are not able to access the Medicaid services because of an insufficient provider, the plans and state are technically not in compliance, and that's a violation. Something else is there are timely access requirements in these contracts, and even I think there was discussion. One of the speakers in the video talked about having to travel really far distance. Well, there are distance requirements in these contracts that plans and providers have to, or plans have to provide and comply with. And the problem is that consumers, recipients aren't necessarily aware that these are protections.
It sounds like all of this could just make a recipient's head spin based on, what's in the Medicaid legislation rather, and what is in these contracts. But what is one of the most common practical issues that you see clients having when it comes to them having issues with accessing the benefits that they have?
I think kind of just what we were mentioning, or what I was just kind of discussing before, is that there's sort of a lack of clarity or not real clear outreach by the state, or just clear information as to what the protections are and what their actual rights are and how that they can insert them. For instance, Medicaid health handbooks, all plans are required, and this is health plans and dental plans, are required to provide their members with member handbooks that should have all of the rights and protections, but members aren't always easily able to access those. And there's also not always a clear door to where the complaint has to be made. And there's almost sometimes an overload of information. And even though ideally the protections were supposed to be provided, or the idea that health plans and dental plans would sort of act as the medical home for recipients and that they could go directly to those plans to get information, that's not always the best situation. There might be, for instance, with complaints like such as timely access requirements, or if they're not able to get into to get the services they need because the health plan or the dental plan doesn't have enough providers, then perhaps the Florida Medicaid agency going to them and doing a direct complaint is the better path. So that's one area, just kind of, there's so much and not knowing exactly the door to take, even though ideally there are supposed to be all these protections in place. And the other point that was made in the video that I think was so important, it was about the changes with the program and confusion, and suddenly made change, having their providers changed. And that's something that just recently, hopefully it will start to resolve. But right now, particularly with dental care, within the last 8 years, Medicaid recipients have received their dental care through about 3 different ways. About 6 or 7 years ago, before there were some changes with the managed care program, the dental was sort of carved down or separate from the managed care program. And then when there were changes to that, dental care was put all together with the managed care program, and recipients received their dental care through their health care program or their health care plan. Now, just within the last year and a half, at the end of 2018, the beginning of 2019, they've changed the program so that dental services are once again kind of separate, and there are now, as I mentioned, dental plans in addition to the healthcare plans. So Medicaid recipients have a health plan and a dental plan, and before they just all had one. So that, I think, contributed to a lot of changes that, people suddenly went to a provider and it was no longer their provider. But hopefully it'll be more consistent in this separation of the dental with the health. People will become more aware of it, and that will really help with the changing in providers and people just automatically being not knowing that they've been changed into different plans.
Okay, and finally, could you please explain what you think are some of the most important benefits available under Florida's Medicaid plan that you think our audience should know about?
Yes, well, there's new benefits. There's something very new, and it is actually really exciting, and I think could be a huge step in increasing access to oral health services. And it ties with that change that I just said, where dental services have now been pulled out of the dental or of the managed care health plans and provided by separate managed care dental plans. And as part of that program, when the state was negotiating the contracts that I mentioned before, where there are some protections there that a lot of people aren't always aware of, in doing that, they required the dental plans to start providing adult dental services to a level that they hadn't before. And I mentioned before, children's Medicaid benefits are very much about preventive care and really helping kids rather than just treating kids. And historically, Medicaid for adults is more about treating. And so under Medicaid law, really it's very limited what dental benefits are provided to adults, and then oftentimes it's limited to dental x-rays and exams that are emergencies or just dentures coverage. So under the new Medicaid dental plans, it's a much richer benefit, and it provides preventive care like cleanings and restorative care, and even things like diabetic testing. So it's really has kind of changed to helping with preventive care, somewhat in line with the children's services. However, there's still limits and each plan might vary. So it's not quite as robust, but again, it's a huge step forward. The problem again, once again though, is these new benefits, they're not going to be an advantage if people aren't aware of them and people, aren't able to make use of them or know their rights and how they can access them. So I think the key to all of these issues, it's education, helping people understand their rights, and then kind of uniting in efforts like this and working together, community groups, working with families and just spreading the word of how we can kind of force compliance, report things, make sure that these benefits and the contract requirements that are supposed to be protecting the recipients are actually being complied with, and that the state is enforcing them. So.
Thank you so much, Amy, and thank you for letting all of our audience know what benefits are available to them and kind of letting there be awareness around the fact that, there are these barriers due to the way Medicaid is set up and the complexity of the system. And thank you also to all of our speakers. At this time, we're going to move on to the Q&A portion for the audience as a whole. So I'll be fielding the questions. Please feel free to put your questions in the chat box so that we don't have multiple people attempting to speak at the same time. And I'll just go ahead and start with a question from, it looks like your first question, Mr. Kenneth Beach, was answered. So,
and Teresa, I don't mean to cut you off. I'm sorry. Yeah. We have the last minute addition of Mr. Akins.
Oh my gosh, I'm so sorry.
Hello, can everyone hear me?
Yes, sir.
Okay, hi. As Kyle said, my name is Chester Akins, and I'm not a dental care professional or clinician, but I did work in the dental industry for almost about 10 years with my father, who worked in the inner city on the quote unquote front lines, providing for individuals who were on Medicaid, Medicare, who probably didn't have the best access. So I do want to echo what the two doctors said. I agree with both of, 100%. One issue about Medicaid, I would say, is that from a policy standpoint, they have to do something about the fee schedules too, because I know that as from a business model, it was almost impossible to keep your practice working, afloat doing Medicaid patients. And so that was one challenge that we had, because we would do Medicaid, but the fee schedules, like you would get like $30 for a filling, depending on how many, surfaces of the filling. And they wouldn't pay for the amalgam. At the time we were doing amalgam fillings, they wouldn't pay for the resin, but we would do the resin. And even though we would get paid for an amalgam filling. So that was something that would have to be dealt, I think, at the Tallahassee level. Now, granted, that was like about 10 years ago, so things have probably changed since then. But during the time, it was really difficult because, we were probably losing money seeing Medicaid. However, my dad felt that was part of his, responsibility to do that, because he felt like, where else would people go? So that was my first issue or thing that I think that would need to be addressed. The second thing is that African Americans, let's just take African Americans in Jacksonville or in the state of Florida, make up like 16% of the state. But if you look at the two dental schools that are in Florida, which would probably be Nova Southeastern and University of Florida, I seriously doubt, and I haven't looked at the classes, but the classes make up 16% of the students who would be dentists. Now, fast forward, you probably won't have a lot of dentists that will go into the inner city areas, to be clinicians. So I think that the dental therapist job or career would be really good. However, you still have to sit up under a dentist. And how many students who will go to University of Florida, you know, spend $100,000 on dental school would want to put their office, you know, in the inner city. So that's another kind of issue that kind of has to be addressed. And like I said, I don't have all the answers to that. But if I do know that, you know, if you go to school for X, Y, and Z, and you know, you probably want to put, say if you're in Jacksonville, you would want to put your office in the town center area or in Ponte Vedra or on the south side somewhere. So, you know, which leaves a whole segment of Jacksonville kind of left out. So I agree with everything that's been said today. You know, I saw it firsthand. You know, I really appreciate everyone on this panel who is trying to make a difference and trying to address some of these issues.
Thank you so much, Mr. Akins, for that perspective from kind of like the business perspective of the issue that we're facing, especially in Florida and even more so in Jacksonville. Okay, so we're gonna go ahead and move to the Q&A this time for real. So we're going to start with, okay, so Mr. Kenneth Peach had another question. Our local FQHCs have mobile dentistry and up to 12 chairs, so tier price dentistry seems to be accessible to the underserved. So it sounds like barriers to oral health literacy and the resulting failure to seek care, question mark. I'm not sure which one of the speakers would like to field that question.
So actually at 12 o'clock today, I was on a phone call with FQHC's dental directors across the state. And they're overwhelmed. They may have mobile portable chairs and they may be able to go out into the community to provide care, but they are absolutely overwhelmed. They can't hire dentists. They don't offer competitive enough salaries. One of the main employers of dental therapists in Minnesota are FQHCs, helping them expand reach. Another great employer example I could use is Children's Dental Services, which used to have 2 fixed sites, a couple of dentists working for them. They now have 8 dental therapists, and they provide care to over 500 sites in Minnesota. Many of them rural, going directly into schools. If you go into schools and provide care within the school, instead of in the dentist office, mom or dad doesn't have to take time off from their hourly job to bring their child to a dentist. So that's an example of how dental therapists can work and why they're needed and why we need them in Florida.
If I could add a comment here, there's a meaningful difference between access and utilization, and those two terms are often conflated. So access, the visual that I hold in mind is whether or not the doors are open, and then utilization, whether or not people walk through those doors. There are a host of reasons why people don't walk through the doors, even when they're available. The bigger problem is typically whether or not access is available, whether there are open doors. But even after those doors are open, utilization becomes a serious concern. So what are some of those issues? They were very well described in that CDC report. About a third of the report focuses only on utilization. But they range from dental fear to lack of understanding that dental services can be helpful for both preventing and treating disease, to logistic issues, whether those be physical distance or waiting times or loss of employment hours or geographic access, although Medicaid addresses all of these. Medicaid has as a requirement that issues of language and transportation, for example, must be provided by the state. Again, often people don't know that they have the right to those services. But I think it's important for all of us to keep in mind that oral health literacy does in fact play a major role, but that's kind of a global term that implies whether or not people understand the value of services. Even when people do seek services only for emergency care, that provides a grand opening for dental providers to invite them in for routine care and for follow-up care. And sometimes the hook to bring people into care is an emergency service. Now, Florida's Medicaid managed care dental programs will encompass more comprehensive adult services that too can make a difference. The upcoming publication of ours looked at the relationship between parents' use of services and their kids. And what we found was that even when children have excellent benefits like the periodic screening, diagnostic, and treatment services, that special pediatric Medicaid benefit, kids have that terrific benefit. If their parents don't have a benefit, the children are much more likely to not have dental services. Congratulations to Florida for expanding its services to adults, and that too can be a hook to bring in more children. Now, both Frank and I are pediatric dentists. We are totally biased in our belief that the greatest focus must be on kids, on that next generation, because we can do things right. We can set those children on a life course trajectory of oral health, good function, and good appearance. Mouth accounts for a range of important physiologic functions, from to eating, to immunity, to protection. There are all kinds of things that oral health bestows on people. And that's why we need to start with the youngest and move them forward into the best possible care.
Thank you. Okay, the next question is from Ms. Tamika Smith. It looks like this one is for Amy. Are state contracts with Medicaid managed care plans public documents?
They have models. So the absolute details and the real specific ones with the actual companies are privileged or private. However, essentially all of the information in there is in a model contract that is available. The problem is there are hundreds of pages, different appendixes all over. I mean, you could pull them off of the Agency for Healthcare website, but you'd be digging through hundreds and hundreds of pages, and some of the real critical information, the consumer protection and those rights are in different places that you'd have to piece them together. So yes, overall they are available, but as far as just really having a value, better outreach and education by both the agencies and the dental health plans would really be what's helpful, and things like really making sure people have access to those enrollment membership handbooks that should kind of outline and kind of have this same type of information, a more consumer friendly kind of manner. But I think what's really key again is just making sure that knowledge is just widespread, and as much as we can as organizations and families, and just word of mouth, really making sure that information is out there as well is really helpful, and making people more comfortable with it and not thinking that they have to dig into a contract that's hundreds and hundreds of pages. So.
Thank you, Amy. We have another question from Mr. Kenneth Peach. Medicare Advantage health plans get brand preferences through star ratings. Do dental plans have star ratings? State Medicaid plans, that is. Do they have star ratings?
No, they don't.
Okay.
And I would add, if you've seen one Medicaid managed care plan, you've seen only one Medicaid managed care plan. How states respond to that master template contract, how various vendors, dental insurance companies respond to that master template that Amy described vary considerably. So the devil really is in the details, but the good news is that that template does require that laundry list of important protections that you mentioned, as well as meeting goals of provider network adequacy, geographic adequacy, ensuring linkage to transportation and language services as needed. Medicaid is tremendously robust. It contains all kinds of protections. The problem becomes those protections happen, and the first step in that is making sure people know, as Amy said, what those protections are.
Thank you. Another question is from Ms. Deborah Thompson, and the question is, what happens when the records show that there is no usage of the benefits? I'm assuming the Medicaid benefits. I think that one might maybe be for Amy, if there's any protections in place, if Medicaid is recognizes that people have these benefits and they're not using them.
Well, and I'm hoping maybe Dr. Calanato will jump in too, because I know he's got experience in and maybe some of the forms, for instance, that are required at the federal level, and just some of the requirements where they look to utilization overall. It's an important part of what the agency is supposed to do to make sure that people are accessing services. And there are, and in fact, I'm thinking of is it the 416 forms, Frank, that are required, where the state, it was one of the things that we were failing so horribly at in Florida, where they could see, and it's how we get the information that's been referred to, that only a certain percentage of Medicaid recipients are actually receiving dental services. And I think, as I think I mentioned before, it was as low as 19% just a few years ago. So, and then there are compliance issues, and if plans aren't meeting those standards, I mean, there are things like sanctions possibly, and like having to change their plans. And Frank, I'll let you jump in if you have anything to add.
Let me respond to that. So in fact, the federal government, the Center for Medicaid and Medicare Services, does look at these 416 forms where the states have to report their utilization, and they have quote, scolded these states. I know that happened in Florida in the past. The plans also, when I was more actively working in the dental school, I was part of a team that used to evaluate and look at the plans were required to submit quality improvement projects. How are they going to increase another couple of % utilization from one year to the next? I don't know whether they still do that or not, but I had some experiences with that. But I'd also like to mention one more positive thing, and I will not mention which of the dental companies it is in Florida. But some of you may know that physicians are now reimbursed for providing early childhood caries preventive dental procedures, including parental education, but also including making a referral to a dentist. And one of these managed care companies in Florida has just recently contracted with me to provide a training webinar to physicians. Remember, physicians don't work for them, but physicians would then refer patients to their dental provider within those dental plans. And I'm actually just finishing up that PowerPoint this week, and hope to present it in a couple of weeks to them. And the goal is to increase utilization. to get parents to understand, because the parents are usually taking the child to a pediatrician before they'll go to a dentist. So there are efforts on the part of some of these plans to increase utilization.
Amy, if I could add to this, the Medicaid 416 report is an annual report that states the percentage, well, the numbers, and then you can calculate the percentage. The number of children who have Medicaid coverage, who have any preventive dental service, any dental service of any kind, a dental service by a dental provider, a dental service by a medical provider, like the one that Frank mentioned. And so it's very detailed. But the Federal Medicaid Authority has, if you will, no teeth at all. They have no capacity to address or redress lack of utilization in the states. One of the most interesting things about looking at those Medicaid 416 reports is that the utilization rates don't vary nearly, I'm sorry, let me get this straight. If you compare utilization rates across states as a function of payment level, it is very surprising to find that there is very little correlation between how much dentists are paid in their state Medicaid program and kids who are getting services. Before we leave the 416 report for a moment, I want to mention that there is no comparable report on dental services. States do not need to report to the federal government their performance on dental utilization for adults. And this is particularly important because in some states, there is no federal standard for adult dental coverage. It's entirely an elective of the states. So there are a couple of states that don't even cover services to relieve pain and infection if that pain and infection happens to occur in the mouth. There are other states that provide limited services, and it sounds like Florida is well in that bucket. And then there are a very small number of states, 4 or 5, that provide reasonably comprehensive dental services. You should always keep in mind that services to adults, as I mentioned before, directly impact services to children. And certainly increasing dental care to adults and using that dental visit to address the social and behavioral determinants of health will benefit children as well. There are multiple opportunities, but the federal government does not just lean on, require, or demand redress when states fail to provide a reasonable level of utilization. However, states can hold their Medicare contractors responsible, and from what Amy has explained, it sounds like that's exactly what Florida is doing.
Thank you so much for answering that question. So the next question is, are dental resources available for frontline workers who, sorry, someone asked another question and my screen moved. Are dental resources available for frontline workers who don't have dental insurance? They work minimum wage jobs at convenience stores and restaurants.
No.
So I would answer that by saying no.
No.
But there are resources for those individuals. They can go to, example, a federally qualified community health center, which operates on a sliding scale. And so their payments that they would make would be adjusted for their income levels. And as I said, in Minnesota and what we hope in Florida, if we ever get to pass this legislation, is that FQHCs are going to be interested in hiring dental therapists because it's going to allow them to expand their services.
We have a real deficit at the federal level in recognizing the essential need for adults to have access to dental services. I had mentioned earlier the importance of going upstream, but when people suffer, when they have untreated disease that causes them dysfunction and causes them pain and infection, they need dental treatment. And so access for those folks is absolutely critical. And yet, Medicaid does not provide an adult dental benefit. The Children's Health Insurance Program that addresses exactly that population of the working poor, children working poor, covers children but not adults. The Affordable Care Act has a mandate for pediatric dental services but not adult dental services. And if I may, I'll share with you the lobbying that I was doing in Washington around the Affordable Care Act. And we had absolutely no success conveying to policymakers the tremendous importance of at least the most basic dental coverage for adults. Trying to get an adult dental benefit. After securing the children's benefit, we worked to get the adult dental benefit. The essential response was, adults can take care of themselves, children are dependent. We need to cover children, we don't need to cover adults. And it demonstrated the disconnect between oral health and general health is physiologically, physically, anatomically nonsensical, but part and parcel of our society's understanding of oral health. As Dr. Danford mentioned right at the top of our time together tonight, that oral health just wasn't on the radar screen. Another anecdote that shows us is that Senator Feingold had a habit of meeting with every people from every county in his state every year around health issues. And he did not hear a word about oral health. One person spoke up. After that, at every town meeting, he defined his health agenda as including oral health. And oral health became the topic of almost every meeting thereafter. Separation just doesn't make sense. And the integration, like having pediatricians do counseling on oral health and making referrals, is a wonderful beginning of a bridge between the medical and the dental systems.
Thank you so much. I'm still trying to wrap my mind around the difference between ailment in the mouth and in the body when there really isn't one. Okay, so our next question is, the gist of this question is, how do we get reimbursement rates changed?
So I'd like to go back to something Dr. Edelstein said. There does not appear to be a direct relationship between reimbursement rates and utilization and participation of dentists within the programs. It just doesn't work. In addition, that's an extremely expensive venture to do that, again, with no proven outcome. And a better way, I think, would be to adapt to whatever the poor rates are in Florida and employ dental therapists who have salaries that are much lower than dentists because their educational period is a shorter period of time. They don't graduate. Chester, I think it was you who said $100,000 in debt. No, the average figure is over $200,000 in debt for graduates of dental schools in Florida. So
I would add, Frank, that it is essential to pay dentists fairly.
Yes.
And too often, very low rates relate to everyone is an economic animal, and we don't want to see care tailored too much to low rates, where appointments are rushed, people are overbooked, where there's too much sitting and waiting to get care. The quality of care is influenced, if not the utilization, certainly the quality of care is influenced by reimbursement, and paying too much of a discount simply invites bad actors and less than optimal care.
And I agree with what Burton said, and I have, when I was more active, I have worked with the Florida Dental Association on asking for increased rates. It's just going to be very difficult in our state.
So I would sum up by saying that it's essential, but it's not a total fix.
Thank you. And this will be the last question that we take for tonight. If Florida expanded Medicaid, would the dental benefit for adults be expanded to those adults as well? And I think, Amy, you kind of touched on this earlier.
Yes, but I do want to say I'm not sure, and I'd appreciate what the doctors have to think as well, if that would necessarily be a guarantee, just the way the state might decide to implement the program, because it is with the federal and state requirements, the state does have a lot of leeway on how they want to implement it, and just the whole way we do the managed care program, they have pulled out certain populations that aren't necessarily required to be in managed care plans. So my guess is that yes, it would be, and there'd be an advantage to trying to make sure that people who are eligible for Medicaid are accessing this, but I wouldn't say it would be 100% sure. That just is my thoughts. So.
At this particular time, the answer is that expansion populations do not need to have, states are not required to provide the same level of benefit to expansion populations, but all states that have expanded have also brought along whatever dental service that they have in their core to the expansion population. So although they're not required to, all have.
Well, thank you very much, Dr. Edelstein, for that closing remark for us. That's great. I just want to take a moment to thank all of our speakers and our interns for their work, not only Kyle Basinger and Teresa Rizzo Sanders, but also Michelle Andrews and Jocelyn Mora, as well as Camille, who also attended, Camille Will Thomas. They've been really working in the background to help spread this kind of information to the community about disparity and solutions to that. And again, I want to thank the speakers, not only for being here tonight, but for the work that they've been doing to spread this information and to try to make a difference in our community. I particularly want to thank Chet Akins for being here. When we started our oral health advocacy program at the Center for Advocacy and Social Justice at the Urban League, we established a fund in his father's name because he really was, as you could tell from what Chet said, he really was on the front lines trying to help people. And we thought he deserved that honor. And we look forward to having more programs like this so that we can really try to make a difference. And there's no question that this is a significant issue that we really have to keep. It's a boulder going up a hill, but we've got to keep pushing it because it's vital to our children. And again, thank you, everyone. And I appreciate your being here, and we wish all of you a great evening. And if you have any questions for our panelists, please send them to casj@jax.org, and we'll be happy to answer those questions. So thank you.
Thank you. Thank you.
Good night, everyone.
Sorry.
Thank you.